All right, so we're going to go through procedures here. I'm going to start with the non-surgical procedures. They are not non-invasive. They all have a degree of invasiveness, and they have some complications that are somewhat unique, but rarer than surgery. But even surgical complications are rare. I want people to know that the severe complications are very rare. So the first is the intragastric balloon. This is the one made by Apollo. There's a different one on the U.S. market. There's several around the world. It is just a squishy type of grapefruit that sits inside your stomach. I'll put a link down below to see more about this. This costs about $7,000 in our practice. It may go up in the near future. It's not my favorite tool anymore because of the cost mainly. I think it is a very good tool. It's FDA approved. It's well studied. I think the people who developed it in its current form with the companies that are FDA approved did a thorough job. I have no complaints about it, and I think the patients who had it are happy enough with the device to have taken the risks that go with it. And it does cause a fair amount of nausea and burping for a lot of people. It's not necessarily invisible, or I mean, you can't see it, but it definitely impacts your daily life. I think people are just disappointed for the amount of money they spent, how strong it is. The average weight loss in the FDA trial was about 22 pounds. The good news is it's only in for 6 months, and at 2 years, the regain was only 2 or 3 pounds on average. But that's an average, and I definitely have had some patients who didn't respond very well at all and didn't lose much weight. I think mainly just when people are thinking about getting a balloon, they want more 40 to 50 pounds, and you will see that out there. You'll see that with any diet as well, some people who lost that weight. So I'd be careful about thinking, well, I'm just going to work hard and I'll do better. It doesn't necessarily work that way in terms of your body's signal response. So some of those folks are lucky. They are all working hard too. There's no doubt about it. But some are luckier than others in terms of that response. Okay, so the procedures that we are doing more, I think, cost benefit wise. Number one is, or two of the three things I'm showing you here today. This is the Aspire Assist. It's a tube that goes in the stomach. This part sits inside your stomach. This part goes through your abdominal wall. And this sits on the outside. This little flange actually sits out on your abdominal wall, and you carry it around. It's a little button, and it's pretty small. You see it against my shoulder, and I'm holding it up close to the phone, or to my camera, but it's not that big. But it's definitely there, and it stays there. The good news is this is built to stay in more long-term. The balloon has to come out at 6 months. This gives good weight loss, and the FDA trial was very successful. I think it's proven safe and effective, or nothing's perfectly safe, but relative to other things, it's safe. We put these tubes in, similar tubes, all the time for people who need feeding or for people who have chronic obstruction of their bowels. Sometimes we will use a tube like that in other situations. Now, the reason I showed that first, though, is it is the weirdest. It's the weirdest concept, because what it does, and again, it sounds like, I just state it first, it sounds like bulimia in a bottle. It is designed for you to eat a regular meal, to chew well. You have to still eat in a structured way, but you don't have to eat in a rigid way with any of these for the most part. But you do have to know what you're eating. You have to make reasonable food choices. You have to have defined meal times, and what you do after you eat, 15 to 30 minutes later, you go and attach this to the button on your skin, and this bag, you basically irrigate fluid into your stomach, and then this tube drains part of your food. About 30% of your meal goes into the toilet. Again, it sounds like bulimia. It is not. It's the furthest thing from an eating disorder. People who do this and do it well are very organized. They don't have to be super organized, but they're not. It doesn't work well with overeating or with not chewing it. You can't have a binge. You can't eat bad food all day long and still drain. But it is like I say, it's a very good tool. I think the people who want this tool and the next tool are for sure the people who never want surgery. I think they still shouldn't be pushed out of a practice and not be allowed to have an intervention. I think they shouldn't be overpromised in terms of what the weight loss is, but it's often, and we don't have a lot of experience with that Aspire Assist gastrostomy or stomach tube, but the weight loss is better than the balloon, and more. It is designed to stay in longer, which is pretty great too. So my mock-up here is not that great, but I'll put the link to this as well. This is a little suture device that goes on the end of a flexible scope. This is the mock-up, so it's all together. This actually is on the handle on the outside of those long flexible scopes that go down through your esophagus into your stomach. And we can actually pass a little needle onto this carrier and then open the carrier up and pull tissue into there, and we can actually suture. This is like Star Trek surgery. We can suture inside of your stomach and fold it together. Now that's called an endoluminal, so inside the lumen, the lining of your stomach. Sleeve, which is unfortunate because that gets confusing. Gastroplasty, that's plicating, not a gastrectomy. We're pulling things together. So we're not actually removing any tissue. On the Today Show, they called it the accordion procedure. I think that it's nice to have a unique name other than another sleeve name that people get confused about. You do leave sutures behind in there, the stitches, and hold things together. And it's been studied very well, and it's very effective. Probably not as strong as any of our operations, but still very effective. And I've done a couple of those, and I've used that tool for other things, and I think it's a very good tool. And I don't want somebody to think that it's going to be the replacement for surgery, but it is certainly an alternative and an option for some people who really don't want to have any type of operation. It's funny how people's perspective is, though, because they'll have had their gallbladder out or hysterectomy or 2 C-sections, but they don't want a weight loss operation because they're afraid it's too risky, when in fact it's probably safer than any of those operations, or as safe as any of those operations. All right, we're going to go on to surgery now, and I'm going to start with one that I basically don't do anymore. I've put in one of these in the last like 8 or 9 years, and I am not that excited about that one even, but this is a lap band, an adjustable gastric band. My tubing's broken here on my model, but it goes into the abdomen open, and then we close this buckle, and then we install this tubing together. So you've heard of this. This is the port that lives under the skin, and that allows the balloon inside the band to be adjusted. A lot of people have these. A lot of people are doing very well. There's at least one report in the literature that shows probably, I've forgotten the number now, 60 to 80% of those at a decade, at 10 years out, are either empty or the band has been removed. It's not because people didn't use them right. It's because the body does adapt. The same way that we can adapt to a lot of things. Our body's got a lot of adjustability. And sometimes the adaptation was bad where the esophagus stopped squeezing. Usually it was just that hunger really happens no matter how tight you make the band. And there are a lot of people who got over tightened and then they couldn't tolerate food, and then they beat themselves up. The worst part about the band is when people come in with shame, or more shame. And I think it's a good tool. I like that tool. If it was the only tool, I'd still do it a lot. But we have, I think, better tools that are over the long term, safer, and more effective. So I basically don't do bands anymore. I won't say I'll never do another one, because I don't think there's anything wrong with it. It's just my least reliable tool. I jumped ahead a little bit. So that's what we do with almost all these operations is small incisions. These are laparoscopic ports. They go in through the abdominal wall. They have a little thing that we can see with the camera through the port to see our way in. This is a 5mm port, so it's less than a 1/4 inch. This is a 12mm port, and I'll show you a little later. Again, it has a tip that helps it go spread the muscle instead of cutting muscle and tissue. So they leave very small incisions. You couldn't even find my incisions from my sleeve. I left that out at the beginning. I had a sleeve 9 years ago, and it's worked pretty well for me so far. I still have hunger. My genes haven't changed. So this is a surgical stapler, and then it goes through, and then we're on the inside, and you can see how we can actually do bigger things through this small port. That's the back end of the stapler. And then we have other instruments with laparoscopy. This is a needle driver that holds a needle, and we can actually put regular suture and regular needle and thread that we normally use in a big operation. We can put it inside the abdomen, open this, and we can sew. So that's how we can do sort of the ship in a bottle surgery. You may have had your gallbladder out that way, or your parents may have had their gallbladder out that way. We do appendix surgery, colon surgery. Here's a couple of other tools just for show and tell. This is a grasper. This is a scissors. You can see they're designed so the tip can spin. I'll show you down here, the scissors. The tip can spin, and we open and close. Sorry, I'm watching myself in the mirror there. And open and close with that. That's just a tissue grasper, and we can rotate it around just with this. So they're very flexible. They allow us to do a lot of the stuff that we used to have to put our hands in for. Since I'm on the tools, I'm just going to show this too. This is a robotic instrument, and it is a little bigger. It's 8 millimeters, so it has special ports. You can see here the tip actually has a wrist that will move around, and it plugs into a robotic console. It doesn't do anything automatically, but so we're directing this the motion. The term robot is a little bit wrong. It's really a computer surgical platform, but it allows us that having that wrist does give us a little more flexibility with our instruments. There's definitely more cost to the hospitals with a robot, and the appropriateness of use is debatable. Okay, I'm going to end this segment, and then we'll go on to the operations on a different segment.